Bismillahirrahmanirrahim. Today we are going to discuss the congenital heart problem. Last time we have discussed the component of cyanotic heart issues, and this time I will focus on the acyanotic heart problem. And the learning objectives of today's lecture are that you can describe the various types of acyanotic heart problems, their clinical presentation, and the complication and general management and specific management of the acyanotic heart issues. So there are multiple heart issues in children. They are divided into congenital and acquired. In adults, most of the cardiac problems are the acquired heart problems like ischemic heart diseases. In children, mostly the problem of related to the heart are congenital, but few of them are acquired as well. The congenital heart issues are divided into acyanotic and cyanotic heart problem. I told you last time there are dozens of issues, but the major chunk, which present 80% of the time, are six acyanotic heart issues, which are ventricular septal defect, patent ductus arteriosus, atrial septal defect, and in obstructive issues of acyanotic presentation is pulmonary stenosis, aortic stenosis, and coarctation of aorta. In cyanotic heart diseases, there are so many complex heart problems, but tetralogy of Fallot and transposition of great arteries are the most common presentation of cyanotic heart issue. And in acquired heart problem, in children, there is acute presentation and chronic presentation of rheumatic heart problem. And the most of congenital heart issues and sometime presenting with a fever in children can be due to the subacute bacterial endocarditis. If we recall the cardiac cycle, you can remember that first heart sound is the indication or initial sign of systole. The systole start with the first heart sound, and when you appreciate clinically, you feel it simultaneously with the pulse. So when you auscultate the heart, the first heart sound is due to the closure of mitral and tricuspid valve, and when systole ends up, the aortic and pulmonary valve close and give the second heart sound, which is louder than the first heart sound. And third and fourth heart sounds are the diastolic phase sounds, which can be appreciated especially in the infants, but usually in adults you will appreciate only two heart sounds: the first heart sound at the start of systole and the second heart sound at the end of systole. So anything happens between the first and second heart sound is the systolic phase of cardiac cycle, and between the second heart sound and first heart sound is the diastolic phase of cardiac cycle. If you see the pressures on left and right sided chambers of the heart, the left chambers are high pressure chambers, and the right sided chambers and the vessel are the low pressure chamber. So see the difference between the upper chambers of the heart, which are called atrium. The pressure gradient is the minimum, while the pressure gradient between the left and right ventricles are significant. The common problem of the acyanotic heart diseases are atrial septal defect, ventricular septal defect, atrioventricular septal defect, which is called cushion defect or AV canal defect, and patent ductus arteriosus, which we will focus today in these defects. The murmur is noise produced by turbulent blood flow. You have to remember when you appreciate the murmur, so across the valve or defect in the heart, it is produced when the blood flow is turbulent. And if the blood flow is not turbulent, you will not appreciate the murmur. And the thrill is a kind of vibration like purring of cat. And when thrill is present in any of the auscultatory areas or in the neck, that signifies the grade of murmur is 4. So if thrill is absent, the maximum grade of murmur is 3. So the atrial septal defect is present in 10% of the time with congenital heart issues. And normally what happens, there is a foramen veil present in utero which facilitate the circulation from right side to the left side. In utero, the lungs are not working, so the circulation of the lungs is diverted through the PDA to the lower half of the body. So normally what happens in utero, the pressure on the right side is more than the left side. So the direction of circulation is from the right to left side. When the lungs opens up and the pulmonary pressure drops down after the birth, so the circulation is from high pressure to the low pressure, and high pressure chambers, as I told you, are the left sided. So when there is a defect between the left to right side, left and right side of the heart, the blood flow will be from high pressure chambers, those are the left side, to the right side. So the different types of defects in the atrial and ventricular septum, we will go through the next slides. The commonest defect of the atrial septum is atrial septum scandum, which is usually at the site of foramen veil. So there will be isolated defect in the atrial septum, and if the site of defect is at the level of atrioventricular valve, the ventricular septum will also be involved. So in that condition, there is usually involvement of mitral or even tricuspid valve as well. So other than the murmur of the atrial septal defect, you may hear the murmur of tricuspid or especially mitral valve. So atrial septal defect, as I told you, the commonest one is the scandum defect, which is present at the site of foramen veil, and it can happen at the site of sinus venosus or at the level of ventricular septum and the pulmonary, the mitral and tricuspid valve area, which is called atrial septum primum defect. So the commonest one is scandum ASD, and the primum ASD is 15% of the time. There are other type of atrial septal defect as well at the site of insertion of inferior vena cava, superior vena cava, or sinus venosus, which are a rare kind of defect in the atrial septum. So what you can do the atrial septum defect, the clinical signs are because of increased blood flow through the defect, especially the scandum defect, there will be murmur of pulmonary blood flow. When increased blood flows through the pulmonary valve, it will give a flow murmur of ejection systolic type, and there will be a fixed splitting because the splitting phenomena is lost due to the communication between two upper chambers, and the second R sound will be little loud because of increase the volume overload to the lungs. So I will repeat, there will be a murmur not because of communication between the low pressure chambers of left atrium and right atrium. The murmur will be because of increased blood flow through the two chambers and going more blood to the lungs, and splitting the phenomena will be lost, so there will be fixed splitting in the both phases of breathing, and second R sound will be little loud, and that's the sign which differentiate it from the pulmonary cyanosis. In pulmonary cyanosis, second R sound is single and soft, and there is no fixed splitting. Splitting phenomena is preserved, and the murmur is in the same area of pulmonary valve. So that's how you differentiate clinically between the two, and you can confirm it on echocardiogram, the site of defect and its dynamics. Atrial septal defect is usually addressed before the school going age, and you can close the defect with the device by doing the cardiac catheterization, or rarely you need to do a surgery for closure of atrial septal defect. The most common defect in the acyanotic heart issues is the ventricle septal defect, and the learning objective will be how we can appreciate the clinical presentations of VSD, and we can differentiate it from other disorders, and what will be the management. This is most common acyanotic heart issue, and 25 to 30% of the time the congenital heart issue is due to ventricle septal defect. And it can be there in the different sites of ventricle septal defect. If you recall from your knowledge of anatomy, the ventricles are like trumpet shape. The middle portion is muscular, and perivalvular attachments are membranous, and if the size of defect is less than half a centimeter, it is called a small VSD, and if it is more than 1 centimeter, it is called a large VSD. The symptoms and presentation depend how much blood is crossing from one chamber to the other. So that is called shunt. So if the size is more than 1 centimeter, it's a larger defect, but presentation depend how much blood is going from one chamber to the other, and mostly this is left to right shunt, and that is called a shunt. The clinical presentation depend on the shunt, and if cardiac output going across this defect is more than 1.5 times than the usual, so it is called the unrestricted defect, and if it is less than that, this is called a restricted VSD. So this is a pictorial presentation of different sites of VSD. VSD can happen in a muscular region or in a membranous or perimembranous area. Sometimes it is in the outlet portion of, rarely in the outlet portion of the ventricle, that is near the pulmonary valve or near the aortic valve. If it is in the vicinity of aortic valve, this is called supracrystal VSD. And these are the different sites of VSD. Sometimes there are multiple holes in the ventricle septum, and it is called a Swiss cheese ventricle septal defect. So it can be in the membranous portion, muscular portion, perimembranous, or in the outlet area. Normally what happens in a cardiac cycle, the blood comes from the periphery through the inferior and superior vena cava, goes to the right atrium, right ventricle, pulmonary artery, and is pumped to the lungs for oxygenation, and oxygenated blood from the lungs comes to the left atrium, left ventricle, and then pumped to the aorta for peripheral circulation. There is never a mixing between the two sides of the heart or even outside the heart. If there is a defect in the ventricle septum, so the left chamber has to pump the blood to the aorta as well as through the defect as well. So initially the left chamber has to work more while the right chamber is receiving more blood. So left ventricle is working more, so there will be left ventricle hypertrophy manifested clinically and on ECG as well in most of the time in the presentation of moderate and large size of VSD. And more blood is going to the lungs, so there will be a pulmonary plethora. It will cause the wet lungs, and it give extra shear pressure to the pulmonary vasculature. So more blood going to the lungs will cause repeated heart failures, repeated chest infections, more work of breathing, more work of the heart chambers, especially the left ventricles, and there will be congestive heart failures repeatedly. And because of increasing pulmonary pressure, there will be a loud second heart sound. And the murmur of VSD is a pansystolic murmur, best heard on the lower left sternal border with no specific radiation, but murmur is usually loud and can be appreciated all over the precordium. As the time goes on, pulmonary hypertensions happen, and there will be damage to the pulmonary vasculature. If ultimately the pulmonary pressure is more than the systemic pressure, the shunt will be reversed, and then deoxygenated blood will mix into the peripheral circulation, and that will cause the acyanotic heart disease turn into the cyanotic heart problem, which is called Eisenmenger phenomena. So initially, in a small defect, only there is a left ventricular hypertrophy because left heart has to work more for the pumping of blood to the aorta and through the defect as well. If the defect is larger, then the right side also receiving the more blood, so it has to work more also, so there will be a biventricular hypertrophy, especially when the pulmonary hypertension happens. So in first 4 weeks there is more pulmonary pressure in the fetal circulation, so usually the presentation is late, and presentation depends on the size of defect and shunt across the defect. So in a defect of smaller size, usually there is incidental appreciation of a murmur when the child presents with some other issues. And on routine examination, you can appreciate the murmur of pansystolic variety at the left parasternal border with usually no other clinical signs. And if the size is of moderate or large size, they do present with repeated chest infections, repeated episodes of congested heart failure and pneumonias, and the pulmonary hypertension can be appreciated if presentation is late. So what happens clinically, the first heart sound is normal. The second heart sound is loud initially because of volume overload. More blood is going across the pulmonary the valve, and more blood is going to the lungs. And later on you can appreciate the second heart sound loud because of pulmonary hypertension. So there is no specific radiation of the murmur, as I told you. And chest deformity can be appreciated because of repeated episode of pneumonia and congestive heart failure, because the lungs and heart has to work more, and the calorie need will not meet the demand of the body. There will be a malnutrition along with the heart problem. So we can compare the different sizes with the presentation of ventricular septal defect. Usually the small defect have a murmur only. Usually a small defect has a loud murmur with a thrill, and moderate to large sizes they do present with the loud murmur, sometimes with the diastolic component, and they have clinical presentation of repeated heart failures and pneumonias. How we can diagnose a patient with VSD? We can diagnose them clinically. On clinical examination, we can have suspicion of VSD, and depending on presentation, we can predict what is the size of VSD. Radiological presentation also depend on the size of VSD. In a larger defect, there will be cardiomegaly, there will be pulmonary plethora, and pulmonary artery can be prominent if the pulmonary hypertension has started. And ECG will show initially the left ventricular hypertrophy, later on biventricular hypertrophy, and it can show the pulmonary hypertension with a strain pattern. And you can diagnose the site of defect and the dynamics of blood flow through the defect on echocardiography. So this is a radiological presentation of VSD with a larger heart. So there is cardiomegaly, there is pulmonary plethora, and you can appreciate the defect, its site, its size, and the shunt across the defect on echocardiography. And then you can plan the management depending on that. The complications, I told you, the malnutrition is a common association of especially the moderate to the large size of defect, and it may present with repeated pneumonias. Eisenmenger phenomena is a complication when pulmonary hypertension usually is severe and pulmonary pressure is more than the systemic pressure, and due to that blood flow is reversed, the shunt is reversed from left to right is rather than right to left shunt. So deoxygenated blood is mixing to the peripheral circulation, and it will manifest as a cyanosis and clubbing, and it happens in a later stage of childhood. And the CCF is a common association of moderate to large size of defect. Arrhythmias can happen if the defect is in the area of conduction system of the heart. So it may be associated with the conduction defects. Bacterial endocarditis is a common presentation, and it happens in the right ventricle because with the shear pressure of blood flowing, and it is going to the lateral wall of the right ventricle, and then it will cause eruption and damage of endocardium, and that will invite the germs to grow there. And if there is a septic embolism is produced from there, it will go to the left side of circulation and can cause episode or attack of stroke or peripheral shutdown in the form of gangrene. So if I will repeat the phenomena of Eisenmenger phenomena, the systemic to pulmonary circulation, there is a connection through the VSD, and more blood is going to the right side and more pulmonary blood flows, that will gradually damage the pulmonary vasculature, so resulting in gradual increase of pulmonary pressure in the form of pulmonary hypertension. As the pulmonary pressure goes above the systemic pressure, the shunt will be reversed and it will manifest as a cyanosis, and because of hypoxia there will be polycythemia as well. So you can appreciate the clinical sign of clubbing, and there is cyanosis as well. This is one of the complication of the larger VSD. And you can see the pulmonary artery prominence in the X-ray chest. How you are going to treat the ventricle septal defect? The smaller defect usually close 90% of the time, and the larger defect, they need general measures of addressing anemia, malnutrition and other complications, and you have to give prophylaxis of antibiotic when the patient undergo the surgical problems, and routine immunization is must, and there is no contraindication of routine immunization in children with VSD. Larger VSD, they need a pharmacological management of preload measures like diuresis and afterload measures like captopril. This is a condition which is due to the volume overload. So usually these two measures are sufficient to control the symptom of a larger VSD or moderate side VSD, and you need a digoxin in the condition where is acute congestive heart failure or heart is dilated. Otherwise, the volume overload measures are sufficient to manage the pharmacological management. And remember, always you have to address the associated problems, and you need to give extra calories to these children. So where do you need the surgical intervention? If the pharmacological management is not working in a larger defect and there is resistant congestive heart failure and the child is not growing well, the pulmonary hypertension is being manifested earlier, so or there is a complex issue of VSD, there is associated problem of pulmonary stenosis, so or there is a site of VSD is in the aortic valve area or the pulmonary valve area. In those conditions, the surgical management is the only solution. Before surgery, sometimes you can consider the device closure. If the size is of moderate size, sometimes you can catheterize the patient, and by cardiac catheterization you can put the umbrella device to close the defect. But if defect is larger, then the surgery is the only option. And if you see the prognosis of ventricle septal defect, 30 to 50% of smaller defect they close in the first 1 year, and remaining of them, most of them, they do close in the preschool age era. So in a smaller defect, you have to follow the patients and you reassure the parent that it will close by itself by the end of 4 or 5 years. In the larger defect, you have to do the surgery, but remember the muscular defects have a better prognosis than the membranous one. And the defects in the outlet areas always need a surgical management. Now we are going to discuss the third commonest defect is patent ductus arteriosus. And patent ductus arteriosus is a normal circulatory pathway in the fetal circulation, and that too functionally closes in the term babies within 72 hours, and in preterm babies sometime it may take longer. There is a muscular component in the preterm babies, and so that you can use the medication to close them. There is an association of PDA with the congenital rubella, which is one of the torch infections. PDA can be association of complex congenital heart diseases, and it can be the only reason of survival in some of the complex congenital heart problem. Although this is one of the association of tetralogy of Fallot, transposition of great arteries, and VSD. So there can be a association with other heart problems. The PDA can be there in the duct dependent lesion as well. So what happens in PDA, the hemodynamics are similar to the larger size of VSD. The pressure on the left side in post utero life or in the childhood life, the aorta is having a pressure of, in adults, of 120, or it is always higher than the pulmonary circulation. So normally the pulmonary pressure is pretty lower than the aortic pressure. So the direction of blood flow in PDA, in isolated PDA, is left to right side. Hemodynamics and complications are similar to the larger size VSD. The shunt is in both phases of cardiac cycle. So mostly the sound will be appreciated in systolic and also in the diastolic phase, because blood comes back from this chamber when the aortic pressure drops down. So because of murmur will be called missionary murmur due to the noise in both phases of cardiac cycle. So there will be a machinery murmur, or there's a murmur in both phases of cardiac cycle. So if you see the location of the ductus arteriosus, this is closer to the left subclavian artery. Mostly it is at the site of origin of subclavian artery. Sometimes it is after the origin of subclavian artery. It connects the aortic circulation to the pulmonary circulation, so more blood goes to the heart, and depending on the shunt, there will be volume overload, and ultimately there will be a pulmonary hypertension, as we have seen in VSD. So clinical presentation will be bounding pulses and manifested as a clinical sign of water hammer pulse. The first heart sound is normal. Initially the second heart sound will be normal, but as the pulmonary hypertension happens gradually, the second heart sound will become loud, and there will be a machinery murmur because of turbulent blood flow in the both phases of cardiac cycle. So the complications and clinical presentation is same as VSD. Murmur will be different, and this murmur radiates to the back, and the pulses are high volume and bounding in case of the patent ductus arteriosus. So larger PDA present similarly as the larger VSD with repeated episodes of congestive heart failure and pneumonia. In preterm babies, if the PDA can be asymptomatic for a longer time, but if it is symptomatic, you have to treat it with the pharmacological agents. In term babies, you cannot give the medicine to close it by the drugs. So diagnosis is similarly on X-ray and ECG and echocardiography. Larger PDA will present with biventricular hypertrophy. And you can diagnose the PDA by doing echocardiogram, and you can rule out the associated lesion before you give the treatment. In preterm baby, if it is symptomatic mean if there are repeated episodes of apnea or repeated chest infections, then you give the medications, and traditional and classical medication is indomethacin in the dose of 0.2 milligram per kg IV in the 3 doses. And now we can give alternative medicine with less side effects, like indomethacin can cause renal damage, or it can injure the premature gut. So you may use alternatively as ibuprofen, or now recently we use paracetamol, 9 doses. So the dose is 10 milligram per kg 3 times a day for 3 days. So if the pharmacological management is not effective, you can close it by the device, or you can do the surgery. The coil can be placed in the PDA by doing cardiac catheterization, and the minimum invasive surgery by thoracoscope you can close, and by bending the PDA. So surgical management is less invasive, and main complication of larger PDA is similar to the larger VSD, and it can cause Eisenmenger phenomena. So I will repeat in a summary what we have discussed today, that the common defect of acyanotic heart disease are atrial septal defect, PDA, and most common this is a ventricle septal defect. And the atrial septal defect can be septum primum defect or secundum defect. Secundum is at the site of foramen veil, which is the commonest one, and the atrial septal defect doesn't close by itself, has to be treated usually the preschool age, and can be closed by the device, or sometime you need a surgery. VSD is a commoner defect, and there are different site, and the clinical presentation depend on the shunt from left chamber to the right side of the chamber, and it may present incidentally if the defect is small with a murmur, or it may present with repeated chest infections, or the attacks of congestive heart failure. And pharmacological management is usually required in larger defects and moderate side effect, and the surgery or device option where the pharmacological management is not effective. And the surgical management can be done if the patient is having repeated chest infections and not responding to the pharmacological management. PDA is a pretty common defect, usually as an association of a duct-dependent lesion in complex cardiac issues, or it can be associated with the tetralogy fellow VSD. Isolated PDA can be closed if it is symptomatic in the preterm baby, not the term babies, and you can address the PDA as it is diagnosed in children if it is symptomatic, and you can close it by the device as a coil, or you can do surgery by lateral thoracotomy, and you can close it by bending it and disconnecting the communication between peripheral circulation and pulmonary circulation. So thank you very much for keen listening, and see you soon inshallah.